Good day, students. This is Dr. Ruskob recording from home where I'm sheltering in place in accordance with the governor's safer at home executive orders for us to mitigate the spread and transmission of COVID-19. I hope that all of you are safe, healthy, and also complying with these recommendations. This is a critical time for public health as we work to mitigate the impact of this important condition in our community. Today, we're going to continue with the third in our series of the 3 lectures related to Chapter 11 of your textbook on the topic of government health insurance programs. And the topic today is Medicare. We previously covered Medicaid and the Children's Health Insurance Program, and the final component here is Medicare. Now, Medicare is a federal health insurance program for the elderly and for selected persons with disabilities. It is a totally federal program. There is no state administration involved. It is administered by CMS, the Centers for Medicare and Medicaid Services. There are uniform national rules across the country that are the same for everybody and in every state. The financing is very different to Medicaid, and we'll discuss that. And the Affordable Care Act did include some changes to Medicare, which we'll discuss in future sessions. So again, 2 main groups of people covered by Medicare: the elderly and selected patients or individuals with disability. There is no income threshold or income ceiling which is needed to require for Medicare. Medicare is an entitlement program, as distinct from our discussion of CHIP and the block grant approach. Medicare is an entitlement. Every American who turns 65 years of age is eligible for Medicare, regardless of their income or other features. And of course, some are eligible earlier than 65 based on disability. So here we see that about 49 million Americans make their eligibility for Medicare based on their age, 65 years of age or older, and 9 million in 2017 met Medicare eligibility through the disability requirements. And again, here you see someone who's totally and permanently disabled and has received Social Security disability insurance for at least 24 months. But this also includes individuals with end-stage renal disease and, for example, a dialysis, and then individuals with the amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. And if you meet these disability requirements, there's no age requirement, so people will meet eligibility earlier than 65 based on these disability requirements. Now, this figure shows the growth in Medicare enrollment from 2000 to 2020, and then projected out to 2050 as we see. In 2020, we have approximately 64 million individuals enrolled in Medicare. That's projected to increase to 92 million individuals by 2050. And this is due to the increasing proportion of the population who are age 65 or older, whereas in 2018, only 16% of our population was 65 years or older. By 2048, 22% of our population will be in that category. This slide shows some selected characteristics of the Medicare population, and I think there's a couple ones here that warrant note and discussion. First, 50% of individuals on Medicare have low income, below $26,200. So remember, there is no income requirement for Medicare, but these individuals, many of them, may also meet their state requirement for Medicaid based on their low income. And this is what it leads to the term dual eligibles, or individuals who are eligible and enrolled in both Medicare and Medicaid. And in 2016, there were nearly 12 million such individuals. It's important to note also that individuals with 5 or more chronic conditions comprise about 30% of the Medicare population. And this is a very important point because this is a driver of increasing health expenses within Medicare. The more chronic conditions an individual has, the more health care resources they will utilize. They will see multiple physicians. They have multiple conditions that require specialists, and they will typically be taking anywhere from 8 to even a dozen medications, not uncommonly. And so these do create significant expenses within Medicare. Again, here we see the number of individuals who have 3 or more chronic conditions. And here the comparison between the 2 different colored bars is to compare these features for those who are Medicare recipients who are also receiving Medicaid versus the other Medicare beneficiaries. And you see that in every case, the lighter colored, these salmon bars are always more extensive for the low-income individuals who are Medicare beneficiaries but also getting Medicaid. So these lower income, low socioeconomic status, elderly individuals also have poor health status, as you will see. And then also it includes a number who are under 65 and also disabled. But the number of chronic conditions, 3 or more conditions, 72% of individuals in the dually eligible, 65 in the other Medicare. So even overall, Medicare population has multiple conditions, again, a driver of health expenses. Okay, there are 4 different parts to Medicare in terms of the benefits that are given. And this slide summarizes those 4 parts. Part A essentially is hospital or institutional care, as shown here, skilled nursing home or hospice. Part B is and everybody gets Part A and is enrolled in that. Part B is a voluntary additional insurance that covers physician fees, diagnostic and therapeutic services. And here, individuals pay a premium that is geared to income, and they have a 20% copayment. The Part A, the hospitalization part, if you're enrolled, there is no premium, no monthly premium, but there is an annual deductible that you have to pay before the Medicare pays for your hospitalization expenses or your institutional expenses. Here, there's a premium, it's geared to income, and 20% copayment. Part C is essentially Part A and B combined together in a managed care program known as Medicare Advantage, in which the beneficiaries enroll in a managed care program for a fixed amount per month to receive prepaid health services. And the Medicare Advantage plan must provide full care for those individuals, regardless of how much they need, based on that monthly amount they're paying. Part D is the prescription drug plan. It's available to individuals who are enrolled in Part A and B. Part C usually includes prescription drug coverage from the managed care program. But Part D is a drug plan for individuals with Part A and B Medicare. And this is usually offered by or contracted out to private sector plans to cover the prescription drugs. In addition, private insurance companies often develop and offer what are called Medigap policies that they sell to individuals enrolled in Medicare, for example, to help them buffer this 20% copayment or other costs that are not covered under Medicare. So a more detailed description of the benefits is shown in Table 11-5. This is right out of the textbook. And the point I want to make here is you see that Part B is quite comprehensive. And this is by intent. And you see that it includes not only physician, outpatient care, all the necessary x-ray, laboratory, emergency department, ambulatory visits, but it includes a preventive physical exam. It includes mammography and colonoscopy and some other screening and diabetes screening and so forth. So there is a considerable amount of clinical preventive care that is included here. You'll see that the Affordable Care Act added some benefits to this plan. We'll talk about that more in future sessions. Now this slide looks at total Medicare benefit payments to beneficiaries enrolled according to what the service that is being paid for, or what was provided. So it's based on a 2017 figure of a total expenditures under Medicare of about $702 billion, which reflects about 15% of the total federal budget in our country. And this is projected to grow to $1.3 trillion in 2029, a growth rate of 7.3%. You can see that growth rate is much, much greater than inflation. And that growth rate is due to, again, the growing number of enrollees as we have aging society and a greater number of people 65 years of age or older. And remember, again, this is an entitlement program. So a person, once they turn 65, they can't be denied Medicare. Now you see about 30% of the expenditure goes to the Medicare Advantage or Part C program. Hospital inpatient care is about 21% of the total benefit payments. Prescription drugs is about 14%. Physician payments are about 10%. Then you have hospital outpatient care, skilled nursing facilities, and other services, and so on. So you see the big pieces that comprise major portions of the pie for Medicare benefit payments. This figure shows the distribution in the country across the states and the variance in the number of individuals who are enrolled in that Medicare Part C managed care plan. And you see that there are some states, a group of states, 6 of them, that have more than 40% of their Medicare population in that managed care plan. California, Florida are notable. In these plans, two companies, United and Humana, had 41% of all the enrollees in the Medicare managed care private managed care aspect. And in 17 states, one company enrolled 50% or more of the individuals. So the challenge with this is that, again, it gets to a point where the competition is strained. We would like to see at least 3 insurance companies in every state or every marketplace to have competition adequate for this efforts. And this is common in some areas and has been a concern for helping to control the costs of these programs. Well, how do we finance and fund Medicare? Let's start with Part A. Part A is funded through a mandatory payroll tax. This is a tax of 1.45% of the worker's earnings, paid each by the worker, the employee, and by the employer. So both employee and employee pay a total of 1.45% each 1.45% of the earnings as a tax to support Medicare. It's higher if they're a high-income individual making more than $200,000 a year. Then this is up to 2.35% of the income. The deductibles and the cost sharing are paid by beneficiaries, and if you have hospital care that exceeds 60 days, there is a co-insurance, which is a significant. That means that the patient, the beneficiary, has to pay a proportion of the total cost along with with Medicare. Now, Part B its financing comes out of general federal tax revenues It is also helped by monthly premiums and deductibles and cost sharing that is paid by beneficiaries. There are higher premiums for individuals who make more than $85,000 a year. Even with these plans and these details, individuals enrolled in Medicare Part B paid on average $6,000 of out-of-pocket costs a year. This was the value for 2013. Part C is the Medicare Managed Care. Again, it's the same funding sources as for Part A and B. These plans require monthly premiums, deductibles, and cost sharing also. How this works is that the federal government contracts with the private plans and pays a capitated rate to that plan, and then that plan must then provide all health services for its enrollees. Finally, the prescription drug plan, or Part D, is funded through general federal tax revenues. Again, also premiums, deductibles, and cost sharing by the beneficiaries. In the case of dual enrollees, some states provide prescription drug assistance to those individuals. So those people who may be getting Medicaid and Medicare also may be getting some state subsidization of their prescription drug cost. And in high-income individuals, there's a surcharge in this program, again, to help support it and help offset the cost for lower-income individuals. Now, figure 11.12 or 11.12 illustrates the proportioning of sources of Medicare revenue for the different parts. And you contrast the salmon color bars with the light purple bar to show the source. And here you see just a striking that this is the proportioning overall, but Part A, 87% of the sources of its revenue are from the taxes that are paid, payroll taxes. And then as you go to Part B and Part D, general revenue is accounting for general tax revenue from the federal government, is accounting for the majority of the sources of revenue. Now, this is an interesting slide because it shows the transition of our population and the stress that this is likely to place on the future ability to fund these entitlement programs, to fund Medicare, for example, or Social Security, which is in a similar situation to this. So here we have on the vertical axis millions of number of beneficiaries in millions, and that is shown by these purple bars. And you see that that is a significant growth, as we talked, from 39.7 in 2000 out to 92.8 million by 2050. But the number of workers paying taxes to support these programs per enrollee in Medicare was about 4 workers per 1 enrollee in Medicare in 2000, and that has declined to 2.8 in 2020 and projected to go down to 2.3 and then 2.3 out from 2030 to 2050. So we've seen a decrease in the number of individuals who are working and paying the taxes to support this program. Here we see the Medicare spending data payments for Part A, B, and D in 2017, and then in 2000, looking back to 2007. So what is the change over a decade? Well, the total payments went from 425 billion to 702. You see that the proportion of Part A payments, which is predominantly, ostensibly hospital care, declined from 47% to 42%, even though the total amount went up. The percentage of Medicare payments related to hospital decreased significantly. as there is a constant work and effort to shift care to the outpatient setting from in-hospital where possible, because that's one of the biggest expenses. And so you see as hospital Part A payments declined, physician outpatient service Part B payments went up by about 3%, and prescription drug payments went up about 3% also. This figure shows that the out-of-pocket spending that Medicare beneficiaries pay and where that goes. And you see here that 53% of the out-of-pocket spending goes directly for services, but 47, quite a high amount, goes for premiums. And within these services that these individuals are paying, now this is out of pocket, so this includes deductibles and other things. Premiums are all in here, and then your deductible, your co-payments, your co-insurance, all of those things are included on this piece of the pie, the 53%. And here you see that long-term care facility payments comprise a significant portion of the total payment for services, and prescription drugs at 9%, medical providers and supplies at 12%. So out-of-pocket spending is spread over a few things, but big drivers are long-term care, medical care through physicians and other providers, and then drugs. This slide is quite complicated, but it relates to the Part D prescription drug plan, and what it shows is different levels of benefit according to the amount expended on drugs. And so when this was set up, it was set up in a clearly what is a very complicated way. First, people who are enrolled in Medicare Part D, they have an initial coverage period, and this payments are made by these plans that are run by private companies for Medicare. If you have $3,750 a year or less in total drug costs, then the enrollee will pay 25%, the patient, and the Medicare plan will pay 75%, the prescription drug plan. Apologize. If you have more than $3,750 in total drug costs up to $8,418, things change a lot. And here the plan pays very little for brand name drugs. And these drugs in this plan are discounted by the manufacturer. And then the enrollee ends up paying 35% here. But if you take generic drugs, then the enrollee pays 44% and the plan 56%. And then when you exceed 8,418 in total drug spending, then the plan and Medicare together cover 95% of it. So there's sort of a coverage gap where the support of the plan and Medicare in terms of the proportion of cost paid really drops down significantly above a total of $3,750 in drug expenses. And this has been referred to as the donut hole, or the coverage gap or donut hole of the Medicare prescription drug plan, Part D. Well, finally, regarding provider reimbursement, physicians bill Medicare on a fee-for-service basis. This is done by assigning a relative weight, or what's called an RVU, relative value unit, to each service provided. And that RVU that's assigned is adjusted to, it is based on the resources needed to provide the service. And then it is adjusted, for geographic differences. The payment is adjusted for geographic differences. So the RVU is linked to the extent of resources needed to provide the service, and and then the payment that is made to the provider is adjusted for geographic differences here. Because, of course, healthcare labor, such as nursing and physicians and various other things, or technology and hospital, all those kind of things are more expensive in bigger cities. And the physician living expenses, all of those things are different in terms of cost of living. In general, though, about 75% of private insurance rates is what the payment is to a provider. A physician billing Medicare can expect about 75% of what he or she would get for the same service to private insurance in general. Hospitals are paid on a payment system called the diagnostic related group. That means that for inpatient care, all services that are provided for inpatient care are categorized according to a DRG, or diagnostic related group. And so, for example, a patient is admitted to the hospital with pneumonia. That'll have a diagnostic related group value, and a certain fixed amount of money will be paid to the hospital, whether that patient stays in the hospital 1 day or 3 days or 10. And so here, this is an incentive to try and control costs. And the incentive here for hospitals is to get people out of hospital as fast as possible, free the bed for someone else, because they get paid for a fixed amount, even if the stay is shorter. And again, in recent years, the push has been to move care from inpatient settings to outpatient settings. Finally, with respect to the managed care plan, there's a capitated rate negotiated by the federal government. Well, this concludes the discussion of Medicare. I think there's a couple themes you can see as we go through this. The first theme, of course, is that, excuse me, it's very complicated. And that's consistent without a lot of what we've been talking about in our healthcare system. Complicated rules about who's eligible, who pays, how much. And in that sense, again, emphasizing to you our healthcare system is really a patchwork of these various types of programs, both public and private. Again, the second important point is that the entitlement aspects of Medicaid and Medicare means that people who are eligible for that will receive that, but particularly Medicare, because that's based dominantly on age, and everyone turning 65 is entitled to receive that regardless of their income or any other features, and the federal government must pay that. And so you see that there can be an increasing burden on the federal budget every year for that, and that growing cost, in addition to age, is driven by people with multiple chronic conditions. 3 or more conditions, as we saw, over 70% of the people. And this means that we have an unhealthy population in general that is driving healthcare costs in later ages, older ages. Now, we have that because we've made enormous success in extending life expectancy. We have extended that greatly over the last 50 to 70 years through reducing smoking, through other upstream public health interventions, but also through health care, clinical preventive care, screening such as mammography, colonoscopy, early cancer detection and treatment, the detection of blood pressure and cholesterol, and prevention of cardiovascular disease and coronary heart disease. All of those things have led to increased life expectancies, and these individuals now are living longer, but ultimately with some health conditions that require resources and require spending more money. And as that projection showed, when that gets to 2050, we'll have quite a substantive number, almost more than 90 million people on Medicare. So a crucial point from a public health point of view is our ability to change our society to a culture of health and to a more healthy living, and have individuals live healthier during their early adult years and middle-aged adult years, so that when they come into Medicare insurance, they don't have as much needs and will have less expenditures and not drive a continuing growth of healthcare costs. Well, thank you very much. I will say then finally about quiz number 4, which is next week. This will focus on Chapter 11 only. It'll focus on Chapter 11, the government health insurance programs, and the 3 lectures that we have done on Medicaid, CHIP, and Medicare. And if you just focus on the slides and the lecture that are pre-recorded, then you will do fine on the quiz. Thank you, and have a great evening.